My name is Marissa Uher. I am a primary therapist at Embark Berwyn, and my background here is I started working at a psychiatric hospital about 5 years ago. I worked there for about 3 years, and I absolutely loved working at the psychiatric hospital. And for personal reasons, I decided to step down into a lower level of care, still working with adolescents. And now I get to work in the PHP and IOP location with adolescents, providing individual, family, and group therapy. So I'll start with the practical challenges. Depending on the location, definitely a lack of resources and access to aftercare. There's a lot of remote areas in our country, and unfortunately, just mental health services are not readily available in a lot of the areas, or just resulting in virtual mental health treatment, and there's just barriers already with virtual. So definitely lack of resources or availability and access to the aftercare. Depending on what the recommendations from the psychiatric hospital are, the length of time and wait to get into an aftercare setting is also a barrier or just a practical challenge. There's wait times for bed availabilities. There's like long wait times for session openings, especially if we're starting with a new provider. And that's for therapy related and medication management. Sometimes the family or that adolescent support system is just unfamiliar with the next steps and just need to be provided with a lot of psychoeducation around what lower levels of care look like. Their support system also just might be unavailable to assist during that aftercare transition, whether it's transportation or financial struggles. Transportation issues can definitely be a huge barrier of what that aftercare looks like. With school, there can be a lack of accommodations from the school or work. And then for emotional challenges, they might be feeling shameful about their experience in the psychiatric hospital, feelings of embarrassment or guilt, feeling like a burden to some of their supports. So definitely recognizing some of those emotional and practical challenges that adolescent and family may be experiencing. And then in the community, there might be a sense of like a stigma or a judgment for somebody that's been in a psychiatric hospital, and recognizing how other people are interacting with the person that's transitioning home, and recognizing that the family, parents, friends, siblings have also might had experienced challenges because of this client. So just monitoring the impact of the hospitalization on all of the other people that are supporting them. Since I've worked in both settings, I've been in discharge meetings in the psychiatric hospital, but also when patients are discharging from like our PHP and IOP setting as well. And discharge meetings are so important because that's trying to set them up for as much success and progress after a crisis moment. So definitely spending the time being provided with what the recommendation is and a resource list of where those providers are available, whether it's in person, whether it's virtual, what realistically is available to the family and the client, and what they're also open and willing to do. So definitely having a resource list and recommendations, asking about the type of therapy that's the recommendation as well. Embark itself, especially like our PHP and IOP, is a DBT focused treatment, and not all providers are DBT, and that's okay. And like finding what works best for that client. There might be like trauma informed therapy, EMDR, creative therapies, even if medication management needs to be included in their discharge. And also if the recommendation is individual therapy, family therapy, group therapy, kind of getting all of that squared away with the recommendation. Also in discharge meetings, there's a lot of terminology that might be new to the family or the client. So asking as many questions as possible so you're understanding what that terminology is. Not everyone knows what DBT stands for. So even like asking what that means. Not everyone knows what options there are for creative therapies. So asking what those questions are. Any diagnoses that are new, any medications, receiving that psychoeducation throughout the treatment, but specifically during the discharge meeting. That way you can follow up with the aftercare providers and have a little bit more information of what you're asking for. During the discharge meetings, scheduling those appointments if that's an available option for you. So if you have that aftercare already in the back of your mind of like where you're going, being able to set up that appointment, signing the release of information forms if that's available to you, and getting all of the contact information so you don't have any questions after your discharge meeting. Also during a discharge meeting, usually there's already a safety plan in place, but being able to update that safety plan for any changes depending on like school accommodations, the household, any just like personal changes that happened before discharge. And there might also be like a school transition meeting. There might be a trigger awareness plan, and just being provided with any crisis hotline numbers during that discharge meeting. Embark, especially our PHP IOP, is DBT focused, and we talk about dialectics and how two things can be true at once, and recognizing that you can feel excited and anxious at the same time. It might be a foreign concept to a lot of people, but also like acknowledging that it's okay to feel those two things. The way that we try to teach it around here is coping ahead for whatever circumstance might happen. We might have to cope ahead for the feelings of feeling excited. I might be really excited, but now I'm impulsive. So how do we cope ahead for that? I might be really anxious and isolative. How do I cope ahead for that situation as well? Being able to identify any triggers of why you're feeling excited or why you're feeling anxious and coping ahead for those as well. And also safety planning. We might be really excited to leave the hospital and not always realistically thinking about what it looks like to return back into these settings because we might not have been there for a little bit. So definitely having that safety plan in place. And just practicing emotional identification. So if you're feeling anxious and excited, can you identify that? What does that look like? And can you communicate it to your supports as well so they can help you through those feelings as much as possible? This is like a fine balance to find. We definitely want to provide that safety, and where's the balance between overprotective and intrusive? For the family and the parents, acknowledging that there's most likely a heightened awareness around these safety concerns, and the parents themselves might be feeling scared. So how do we still put these safety plans in place while also recognizing kind of our own barriers as a parent? Not everything has to be therapy related. We're still allowed to do like our family time activities. We can still have family like dinner together. We can go play Uno later and not have therapeutic questions come into play. So recognizing just that separation. Asking questions rather than assuming something is wrong. That kind of goes with the heightened awareness around things. This is kind of an example that we use here. Related to self-harm, one of the warning signs might be someone wearing long sleeves in the summer, can be a warning sign for self-harm, but also asking the question of not everyone wearing long sleeves in the summer is self-harming. So how do we ask the child, like, why are you wearing long sleeves today? So we might be using our context clues and facts from the past to inform our questions, just not assuming what the answer might be. Definitely having the discussion around trust. We might have these safety concerns because something has happened, but also how do we build back the trust? And that way the client themselves feel like they have some form of control with their family. Recognizing our boundaries of the relationship. So the role of as a parent versus the role of a therapist. There's some separation there, and parents do not have to take all of it on themselves. Leave room for the therapist to also ask the safety questions and trust that clinical recommendation that the therapist is also concerned about the same things, but also giving the parents the opportunity to stay as parents. Practicing that validation and empathetic listening while the child is sharing. Avoid minimization. So if someone's transitioning from the psychiatric hospital and it might have come as a shock from the parents, kind of avoiding the quotes of like, you seemed fine, like I didn't know that something was wrong to this extent. And also as they're transitioning home, not necessarily setting the goal of just get back to how you were or just get back to your like normal happy self. So avoid minimization as they're returning home. We definitely want to still have an emotionally safe environment, and how do we do that while still having these like tougher conversations? So creative communication might come into play here of we're not directly asking safety questions, but we might have kind of something on our refrigerator that we check off if we have a safety concern. We might have a suicidal ideation tracker. We might have a safety concern tracker in general and a mood board, but we're not directly asking those questions. It might be just the child like putting up a smiley face if they're good that day and don't need a check-in. It gives that kid kind of more control of how they want to communicate with the parent and not having the parent consistently asking and checking in. I kind of said this earlier before, but always having that safety plan in place before returning home. That way the professionals and the therapeutic support were involved in it and it's coming from the clinical recommendations. It's not always having to get taken on by the parents. They're there to implement it, but not always change it themselves. Providing access to those supports after the psychiatric hospitalization, supports even like friends. So we need to hang out with our friends, but how do we also still have boundaries around it? We may not be sleeping over our friend's house, but we get picked up at 10 o'clock. So recognizing that we still want the child to have access to their supports and access to things that they've enjoyed in the past, but how do we still have that boundary? That way it's still safe. Another one that comes up is the phone. So how do we like give access to a phone, but also kind of have safety planning around that? So they might have screen time. They might just have you turn in your phone at 8 o'clock. And how do we still give them access without putting too many boundaries in it? I think the biggest thing too is like providing grace and an opportunity for growth for that kid, for those parents, for everybody else that's involved. Change does not happen overnight. It happens over a really long length of time, and it's also not linear. So like setbacks are going to happen, and recognizing that, but that does not mean the person is not making progress. It doesn't mean they're a failure. Just recognizing that this is the process of recovery and how we have mindful conversations around that. So if we're recognizing that there's a safety concern, if we're recognizing that there's maybe like some impulsive behaviors, how do we communicate about it? How do we talk about it? But also not bring up maybe like the 10 things they did in the past. How do we just recognize what's going on? It's a safety concern, but also recognize the progress that's currently happening. Especially if medication is newer to the client and also the family, it may feel intrusive at first. So kind of like any new routine or new habit that we're trying to establish, repetition is key. And kind of getting into the groove of things, how many helpful reminders can we have for ourselves that we're receptive to and that don't feel like they're too intrusive on our day-to-day life? And giving yourself a few weeks to adjust to these new medications and the routine of taking the medication. It might be like setting alarms for yourself, not providing your like reminder to snooze it. That way it like keeps coming up. Like set one alarm and like that is the time that you take it. Reminders on your phone, written reminders, any like calendar updates, a medication organizer. There's like many different varieties of like pill organizers, whether it's like per day or per time of the day. So having like a physical organizer for yourself. And then depending on the safety plan, many of the medications will be locked up anyway. So some of the parents will just have to assist with the reminders of this is the time we go to the safe or the medicine cabinet, and having that additional support from the parent or provider to help maintain that medication routine. And then once that medication routine is established, the reminders may not feel as intrusive anymore. We may not need the alarm to go off every time, or we're more receptive of when the alarm does go off. We're not like, oh, it's medication time, but it's just kind of a part of our day-to-day life now. During our discharge meeting, we definitely encourage signing the ROIs, especially if the outpatient providers and aftercare was already identified. So already having that paperwork provided and signed if that's available to you during the discharge meeting. Always provide the outpatient providers with the discharge documents and the recommendations from the psychiatric hospital. That way there's the continuity of care of what the actual recommendation is, what some of the treatment goals were that they were working on, what the progress was in those treatment goals, and just how the further support around medication management. It's usually all on the discharge documents, so as long as the ROIs are signed, the providers can communicate back and forth between each other. If the parents are looking for a little bit more contact with the providers, just including all of the providers on an email thread and introducing themselves to each other, and then also creating a follow-up schedule. So if there's a schedule between an outpatient therapist and you're seeing them once a week, allowing the inpatient services to know that, so on a weekly basis they might just be in contact with each other. Every client is different, so definitely asking them what their specific triggers and stressors have been in the past. This includes like any person, any location, certain objects, any like sensory things that have been happening in the household, at school, in an outside environment. Definitely trying to personalize the plan to a person's specific triggers and stressors. In general, the recommendations for a safety plan would be locking up any sharp objects, medications, firearms, any objects that are strong enough for strangulation, locking up any other substances or alcohol that's in the house. And probably like the main areas in the household where these objects are found are the kitchen, the bathroom, and like a garage or a shed. So definitely taking into consideration the areas of a household at least where more dangerous objects are found. This includes like razors, any knives, and also cleaning chemicals. So making sure that we're aware of any potential hazard, especially in the household. School is kind of a different story. There's like different limitations a school has, but a school can also be aware of a safety plan if necessary for those environments. With the razor specifically in a bathroom, this may lead to different types of body checks after a shower or limitations to personal hygiene objects. So making sure that that's part of the safety plan or just the conversation with the client. Other safety concerns might be phone use, so monitoring what apps they have access to, what people they have access to, maybe putting like a location tracker on the phone if the client is moving around often or like going to school or work or something. They may not have access to like locking their bedroom door and like always having to keep it open, thinking about access to different spaces in their house. Also identifying what a safe space in the house looks like. If there's a like soft blanket that is more helpful, if there's a certain sound and we have a sound machine or a candle that is a good scent and it is calming, how do we create a safe space in that house? That way, if that client needs a break and they're at home, where can they physically go to feel safe? And again, that kind of looks different for everyone. Making sure they have access to their coping skills. So if they like coloring, they use tip and use the ice. How do we always have access to coloring supplies, and where can we find ice at all times? It might be having the like transportable ice packs, and that's kind of the thing that we have in each room. Do we have a fidget bin in each room? Just making sure that we have access to all of our coping skills depending on the location in each house. Respecting when a client needs a break and they still need their individual and alone time. So how can we provide that to them while also maintaining safety? If they need to walk out of the kitchen and go sit in the living room, as long as that is a safe space, that's okay. If they identify their bedroom as a safe space, how do we make sure that their bedroom is safe while also maintaining their privacy? Maybe they're allowed to go in their bedroom, but the door is open. So how do we just maintain the privacy and boundaries that an individual person needs while also having that safety plan in place? And then along with physical safety is also emotional safety. So practicing that active listening, empathetic listening, validation when they're sharing, allowing the client to talk about uncomfortable topics. If it happens in the household, how do we still have that conversation and also maybe prepare it for a therapy session afterwards? And then for the parents to model positive behavior. So if we're looking for somebody to reduce screen time, practice a healthy sleep routine, eating habits, and have like a good school life work balance, how do we also model that? That way we're demonstrating what healthy, safe behavior looks like, and that client might also be receptive to practicing it themselves. Definitely the client's emotional readiness to return back to the school environment. During our PHP here, a lot of our clients do come from a psychiatric hospitalization to PHP, so they're not going into a school environment right afterwards, which also means they're out of school for a longer amount of time. And transitioning back into a school can be an emotionally taxing time of your life to return back to that school requirement of actually doing work that you've also missed and probably don't understand. You're also now seeing friends and other students that you haven't seen before or in a long time, and you also have to explain where have you been? And that might be a really personal question that you don't want to answer. So recognizing the emotional readiness of somebody to return to that school environment and how does the school interact with their aftercare. When we have a client in our IOP program, we're in contact with the school. That way the school knows that this client does not have time after school. This client may go to school 9 to 2:30 and then they're in our program from 4 to 7 the rest of the night, and working on school assignments and finishing them on time can be really challenging. So making sure that the school to some extent is aware of the mental health treatment that they're receiving and recognizing that there can be accommodations for that, especially if they're in an intensive mental health treatment after the psychiatric hospitalization. The client might be able to receive accommodations around time extensions. They might just be medically excused from a lot of their schoolwork. They can gain access to a counselor with a pass rather than having to ask the teacher to actually go to the counselor's office. They might have access to different breaks. There might be a support room now in the school that they have access to. And then also, again, having access to their coping skills. So if listening to music, using an ice pack, and coloring are the client's identified coping skills, how does the school also allow them to have access to these skills as well? And also having realistic academic goals for a client of maybe we're not a straight A student, but we're maintaining an average grade. Maybe we're using our time extensions. They're not getting in on time, but we have this extension now. And we might have to drop down some of our classes. So we may not be in all AP classes, but we're still in honors. Or we might not be in our honors, but we're at kind of the natural level of classes. And we might have to be dropping down some of our clubs or other extracurricular activities, but just recognizing what realistically we can accomplish returning back to school and what limitations the school environment might have to appropriately accommodate this child as they're returning back. My recommendation is always to have professional help after discharge, so you wouldn't necessarily have the time not to have it. But definitely isolation. If that client's no longer going to school, if they're not going to their extracurriculars, if they're not seeing friends, even if they're isolating in their bedroom and not coming downstairs to eat dinner or even have dinner. So definitely isolation. If you notice any of their ADLs changing, so they're not showering as often, they're not brushing their teeth as often, their sleeping habits have changed. This means like oversleeping and also undersleeping. And also if their eating habits have changed. So any overeating, undereating, hiding eating, so like sneaking snacks in their bedroom. So any just changes with their ADLs. Any potential signs of self-harm. I kind of used this example earlier with like the long sleeves during summer, but kind of being aware of any of those signs of self-harm, unhealthy eating habits, any substance use, any signs of that. If they're not taking their medications or reporting having a difficult time taking their medications on a routine basis, if they're not engaging or enjoying their previously enjoyed activities. So if I really like to play guitar and I used to play at least once a week, and now I either don't play or I don't like it anymore, that can be a potential sign. The client might be very quick to anger or frustration or sadness, also difficulty communicating those emotions or needs. Any difficulty maintaining their friendships, so they might have lost a lot of friendships and that might be a difficult change that they're struggling with after discharge. Any like increased impulsivity or poor decision making, declining academic performance, and also difficulty talking about the future, feelings of hopelessness, difficulty identifying like what they see for themselves or making goals for the future. Practicing mindfulness and gratitude. So if you're recognizing any sort of emotion, recognizing it for yourself. We are human and we experience emotions and that's okay. So like giving yourself confidence that you can experience an emotion and handle it and manage it, and practicing gratitude for yourself of going through something that's difficult and hard and you made it through it, and recognizing the steps that you took to get there. Giving yourself grace during the healing process, acknowledging the progress that you have made, even in the small moments. So even today, if I just woke up and got out of bed and then I sat on the couch the rest of the day, that might still be progress for somebody, and being able to recognize that. Managing those feelings of shame or guilt, if that's what we experienced once we were discharged. How do we acknowledge it? How do we manage those feelings? That way they don't continue to impact our progress, relationships with others, our daily functioning skills. Using our supports that are provided to us, we have to be receptive to the things that are around us, and how do we utilize all of the things that are provided to us in order to maintain that motivation. Advocate for our needs, and also surround ourselves with those people who are supportive and understanding. That way we still feel supported by the people around us and continue to feel motivated to actually attend our treatment. So if we have medication management and therapy, making sure that we're still attending those treatment consistently.